Hi, thank you for joining our webinar today. My name is Gladys Ng, and I am a reconstructive urologist here at UCLA. Today, we're going to talk about male urethral stricture disease. Please ask questions on Twitter using the hashtag UCLAMDChat. So, topics that we're going to talk about today are what is a urethral stricture, the relative anatomy, signs and symptoms of a urethral stricture, how is it evaluated in the clinic and in office, also causes for strictures, and also treatments, follow-ups, and a general summary of the condition. To start off, this is an overview of the urinary system. Urine is first made in the kidneys as the blood is filtered through, and it comes down the ureters where it drains and sits into the bladder. And the bladder's sole function is two functions: to store and empty out the urine. The urethra is the urinary channel below the bladder, and this is where it's a special channel where it is lined by special protective cell layers, and its main function of the urethra is really to empty out urine and also transport semen from the male reproductive organs out through the opening of the penis down here. Functionally, the normal passage of urine begins with relaxation of these muscles down at the pelvic floor. Once the bladder feels full and it squeezes the urine out, the bladder neck here, which is also a method of urinary control in males, relaxes, and the urine passes through this prostatic urethra, or the urethra that is surrounded by the prostate gland. Then it comes through this segment of the urethra, which is surrounded by the pelvic floor muscle, and these are the muscles that are typically squeezed when you want to hold your urine. And then the urine passes through this part of the urethra, which is lined by highly vascularized tissue called a corpus spongiosum. And this is the area that we will be talking about. Stricture disease occurs from this point forward in this part of the urethra, which is lined by this highly vascularized, or meaning tissue that has a lot of blood supply. And in this part of the urinary channel, this is where the stricture disease occurs. In this picture, this gives you a relative orientation of the anatomy on a different side view. You can see that the highly vascularized tissue of the urethra starts right behind the scrotum in this area and comes all the way out this way. This is called the bulbar urethra, because this is the area where it kind of dips down below the pubic bone, and this is where the urethra turns its channel up into passes behind the pubic bone and up into the bladder. And this is the shaft of the penis, or the penile urethra, where the urethra is on the shaft of the penis. And this is where we call the opening, or the meatus of the urethra. And it's important to point out these areas on the urethra because some of the strictures and their relative repairs occurs in these different sections. And I just wanted to have you have an understanding as we go forward. So a stricture is really an abnormal narrowing of the urethra where scar tissue forms, and this scar tissue causes a blockage of the urinary channel. So what are the causes of urethral strictures? There are generally 5 broad categories that I kind of approach it with. And really, these are arbitrary categorizations because it helps when I evaluate the patient. As to how to plan their repair. They're overlapping categories, and really at the heart of all these causes is the idea that there is a disrupted or inadequate blood supply to that area of the urinary channel that is supported by that tissue, the corpus spongiosum that I mentioned, that has a lot of blood supply. So it is because the blood supply is inadequate or disrupted. That's why scar tissue forms, and then you get strictures. So just to start off with traumatic injuries, a common type of traumatic injury is a straddle injury, or this is what happens when someone walks on a fence or falls with a deceleration injury to the crossbar of a bicycle, where the urethra, or the pelvic floor, hits a hard surface, and this is typically what happens. So someone falls in between and hits a hard surface, and this is where the trauma occurs, and you can see that the pubic bone is here, and the pubic bone crushes the urethra against a hard surface, and there's trauma to that area. This can be so bad as to sometimes the pubic bone can transect the urethra, and sometimes patients will present to the emergency room with urine leaking into the scrotal sac and blood coming out the tip of the penis, and the patient typically is unable to urinate as the urine is diverted into the scrotal sac. There could also be penetrating injuries such as gunshot wounds and also stab injuries to the front part of the urethra and penis. Another cause of urethral strictures are inflammatory causes. One common or relatively common type of condition is lichen sclerosis, and this is a chronic inflammatory process of the penile or genital skin. And what happens in this cycle is that the skin becomes scarred, becomes brittle, and then torn, and then that whole process goes over and over again, such that you form a scar-looking tissue of the skin and also the head of the penis, as you can see in this picture. And this is really inflamed and brittle skin or tissue that surrounds the penis. And what happens is that usually strictures occur at the head of the penis or where the opening comes out, and sometimes you'll see patients that are unable to urinate because the opening of the urinary channel is scarred down. We don't see this common, but post-infection strictures usually occur after a sexual transmitted disease such as gonorrhea. Typically, because we have access to healthcare in this country, we see this more in a developing country. And it's not typically a one-time infection with gonorrhea. It's usually a chronic, untreated infection with gonorrhea that leads to stricture disease in the infected patient. Another population of patients that are often quite challenging to treat is patients with a congenital condition called hypospadias. This is when they're born, their urethra is not formed in the correct place, and it's usually formed in the underside of the penis. And usually our pediatric urology colleagues will see these patients first when they're young and do their repair, a surgical repair, to correct the abnormality. However, sometimes these repairs fail in time, and we see them as adults. So for instance, in this patient, you can see that you cannot see the opening of his penis or the urinary channel, the urethra. And if you look at it on the top side, you see that there's a lot of scar tissue from his previous repair. That's what makes subsequent repair difficult. And also you can see that he came in because he had difficulty urinating because the opening to his urethra was pretty much closed. Other causes are patients that had previous instrumentations, sometimes with transurethral surgery, sometimes even with traumatic catheter placement. Catheters are sometimes placed when you go into the hospital to monitor your urine output, and sometimes either the catheter itself or the placement of it can cause trauma to the specialized lining of the urethra, leading to scar tissue. And then there's always unknown causes for urethral strictures as well, which can be quite a large population of patients. So what happens if these strictures are left untreated, and what are the complications? The way I look at this is there's two broad categories with the complications of untreated urethral strictures. Patients can have infectious complications or functional complications of voiding under high pressure. So infectious complications are that patients can have prostatitis or infection of the prostate gland, which can lead to chronic pelvic pain, or they can have stones that form in their bladder or their urethra. They can also have backup of urine, infected urine going down to the testicles and epididymitis or epididymis and causing infection of those two organs, which leads to a swollen, tender scrotum. They can also form abscesses or little pus pockets around these glands that surround the urethra, leading to these periurethral abscesses. And sometimes if these pus pockets progress, they can form abnormal connections to the skin, leading to urine draining from the urethra out to the skin, which is what a fistula is. And then with the most morbidity is Fournier's gangrene, where this is a necrotizing skin infection, which can have a high morbidity and mortality, which requires a surgical debridement of the whole genital area and perineal area. With functional complications, high voiding pressures lead to a thick-walled bladder. This affects the function of the bladder and its capacity to store urine. You can also have inability to void acutely, requiring a trip to the hospital for drainage. Also, that backup of urine from the bladder not being able to be expelled, and also a thickened bladder wall can cause the back pressure up to the kidneys, leading to swelling of the kidneys, which is what hydronephrosis of the kidneys is. And this can lead to acute renal failure. And sometimes you can have patients present with acute renal failure, have to undergo temporary dialysis to find out that they have a urethral stricture disease. So as you can see, initially some of these symptoms can start off as annoying to your quality of life, but if it progresses, it could really impact the quality of your health overall. So what are the signs and symptoms of urethral strictures? So a lot of the symptoms are difficulty with voiding, namely there's a decreased force of urinary stream. Also quite common is a feeling of incomplete bladder emptying, also needing to strain when you urinate, and also sometimes when there's scar tissue, the urine doesn't come out into a straight stream, it comes out splayed. Other signs and symptoms are painful urination. Sometimes it hurts to urinate. I've also seen patients with bleeding after straining so hard to squeeze the urine out. And again, urinary retention, inability to urinate at all, requiring a trip to the hospital. Or they can have recurrent urinary tract infections, which is not common in a male patient. So it's good to know what these symptoms are so that you can be evaluated by your doctor if you have any of these symptoms. There's other conditions that kind of share these same symptoms, but that's why it's important to see a doctor if you have these symptoms. So now that the patient has a stricture, what do I do when I see them in clinic to evaluate them? First off, I'd like to know a little bit about their health history, their medical history, if they've had surgeries before, because that's important, surgery to the genital areas, if they were born with any congenital abnormalities. Also, in general, what their lifestyle habits are, if they're a smoker, sometimes that affects my repairs, and also if they're diabetic, because that also affects their healing process and of the repairs that we do for them. Physical exam is usually unremarkable, but however, if you are a patient with lichen sclerosis, typically we can see that on the skin itself, or with the history of that congenital abnormality, the hypospadias, where the urethra forms on the underside of the penis. And if they had previous scars to the area, it's good to see and know what length of shaft they have, and also what kind of skin there is surrounding the on the penis. It's also good to evaluate the urinary flow. You can either do that standing up in a full bladder. I'd like to see how good their flow is, and or else there's a machine that can objectively quantify their flow rate. And then also, it's good to measure just do a quick bladder scan with an ultrasound and see how much urine is remained or retained after they void. But to actually evaluate the stricture itself, there are several ways to evaluate it. The most common way is by urethrophy, or basically using dye and under X-ray, live X-ray, to look at the urethra itself. So how this procedure is done is that the patient is placed in a special position, and dye is injected through the opening of the penis, through the urethra, and we can assess the whole channel itself, as you can see here. This is the tip of the penis. Dye is being injected, and you can see what the normal urethra looks like and what an area of diseased area looks like of stricture. And things that we're looking for when we do this kind of dye study is, one, if there is a stricture. Two, how many strictures there are. Sometimes you'll have patients with several strictures along the way. Three, what is the location of the stricture, because the location of a stricture really determines what kind of repair you're going to do. And also, how narrowed is the stricture, meaning is there dye that goes through the stricture, or is there no dye, meaning that the strictures or the urethra is completely obliterated. The other study I mentioned up here, that study where you inject dye into the bladder is called a retrograde urethrogram, or we typically call it a RUG. But the other study worth doing is also called the voiding cystourethrogram, or VCUG, meaning that once the bladder is full, it's good to have the patient void so that we can also evaluate the backside of the urethra here. Which sometimes is difficult for the contrast to get through if there is an area of stricture, and also if there's if the pelvic floor muscles are tightened. So these are typically the two studies we do to evaluate the stricture. Another study that can be done in the office is a cystoscopy, which is placing a telescope. This telescope is about no larger than half a centimeter, a little bit smaller than half a centimeter in width. And we adequately numb the urethra, and what we do is place this telescope in through the urinary channel and look at the stricture itself. As you can see in this picture right here, there's a picture of a stricture. This study's advantage is that you can see what the tissues look like. You can see the stricture. You can see how pink the tissues look like, because ultimately we're concerned about the blood supply and the oxygen to the tissue. However, the disadvantage of this study is that you can't see beyond the stricture because the scope won't go through, and if there's other strictures back there, you won't be able to tell. And also, you can't tell what the length of the stricture is, which is important information in the repair and reconstruction of this condition. So what are the treatment options for urethral strictures? Generally, there's three: dilation, urethrotomy, or urethroplasty. And we're going to go through each of these in a little detail. So to start off, there's dilation. This is the oldest known treatment used in the last 3,000 years for treating urethral strictures. And the goal of this treatment is really to sequentially stretch the scar tissue without tearing. Once you have tearing and bleeding, that means the tissues are torn, and then you'll restart the whole process of scarring and fibrosis and scarring, leading to more stricture. So what instruments are used? We typically use these metal sounds, and if you can see, they are metal sounds that are perfectly cylindrical and smooth, and they slide in gently, getting larger to their number size, and that's how we gently stretch out the scar tissue. And so you start small, and you sequentially move forward to a larger size. More recently, with our new technologies, there's also balloon dilation, where a catheter is placed into the urethra, and the balloon is slowly inflated with dye, so it can be done under X-ray. This is an outpatient procedure. There is a pretty low risk of complication, and success rates range from 35 to 78%. But it declines with each subsequent treatment. And it is really a non-curative treatment. And the range of success rate really is because it depends on the length of follow-up. In the next treatment option, there's direct visual internal urethrotomy. And this was introduced in the 1970s, so it's been around for maybe about 40-some years, or plus some years. And it is an outpatient procedure. In this procedure, a scope here is placed into the urethra, so it's done under direct vision, and a knife or a laser, or any kind of energy, typically a cold knife, is used to cut through the stricture in the urethra. And there's many methods to cut through the stricture. Some people like to cut radially around, or more commonly, people like to cut at the 12 o'clock position. And success rate is a wide range again, and from 35 to 90%. depending on the follow-up. And it also declines with subsequent treatment, and usually a non-curative treatment. In this prospective randomized study, comparing the recurrence rate after dilation and urethrotomy, using either stretching or cutting through the tissues, the two methods that we just spoke about, they found that the stricture-free rate at 6 months' time, about here, is really only 50%. And the other conclusion from this study was that there really isn't that much difference in the recurrence rate for both treatment options. Sorry. So this leads to my third treatment option, which is the urethroplasty. And this is really not one surgical procedure. It's really many types of surgical procedures, but it's really an open surgical repair. I'm sorry, this is a slide we're talking about. I jumped to another one. It's really open surgical repair to rebuild the urinary channel. And there's three broad ways to look at this surgery. You can either excise the scar tissue and reconnect the two ends, or you can substitute with a graft, which is taking tissue from another part of the body on an area of the tissue of the urethra that's narrowed to make it less narrow. Or you could take a flap, which is I'll show you pictures in a little bit, a flap which is taking local tissue with its own blood supply to put onto the area of the narrowing of the urethra to make it wider so that urine can pass through. And there's also staged repair. And typically, staged repair requires several operations, but the first operation is really to lay down the foundation to completely rebuild the urinary channel. And this surgery is usually reserved for patients with complex disease or those with multiple failed previous surgeries. So some examples and just kind of splitting things up into the anatomy that we've initially discussed. When you look at the bulbar urethra, the area of the urethra that dips underneath the pubic bone, if there's strictures in the bulbar urethra, which is actually the most common area of strictures, there's a bulbar urethroplasty, excuse me, and depending on the length of that stricture, you can either excise the scar tissue and reconnect the urethra, or you can take a buccal graft, which is a graft aligning from the inside of the mouth. As you can see here, this is a buccal mucosa graft, which is a graft taken from the inside lining of the mouth, and we can use that to substitute in the urinary channel to make the narrowed segment wider. In the penile urethra, or the shaft of the penis, if there's strictures in that area, you don't want to excise and reconnect because it can cause shortening of the penis itself. So that's why the approach to repair strictures in that area is either a flap, as you can see here, this is local tissue that is used and it has its own blood supply, and then this is used to repair the urethra itself to substitute and make it larger. Or, as I mentioned, you can do a stage repair for those that are difficult, have multiple surgeries, and also sometimes those that involve the tip of the penis or the opening of the penis. So urethroplasty is currently the gold standard of treatment for urethral strictures, but it does require a reconstructive specialist because it is specialized surgery. It is an inpatient procedure, but however, lifetime success rate is about 75 to 100%, and that's across all broad spectrum of stricture disease, including those that had multiple surgeries in the past. And if you look at just bulbar urethral strictures itself, there's a greater than 90% success rate with either excision and reconnecting the two ends of the urethra, or with a substitution with a buccal or buccal graft. Okay. This is just worthy to note, which is a treatment alternative, which is called a perineal urethrostomy. Depending on the patient and their expectations, also their comorbidities, sometimes it's difficult to reconstruct the whole entirety of the urethra. So there is an alternative, which is to make an opening at the urinary channel right below the scrotal sac, which is where the perineum is. And the perineum is the area behind the scrotum and above the anal opening. And in that area, you can make an opening to where the urine can drain, and candidates are those with multiple failed repairs of surgery, and with patients that are sick, with a lot of comorbidities such as other health conditions that would, systemic conditions such as diabetes, and if they're not well and healthy. It's usually the last resort alternative. So just to compare all the treatments that we spoke about here, going through everything again, there's dilation. It's low complication rate, outpatient procedure. There's no risk to injury to surrounding tissues or nerves that would affect any of the urinary control mechanisms that we mentioned in the first couple of slides. However, disadvantage is that it is not curative and it does have a high recurrence rate. However, you can kind of combine this with if your patient wants this, it can be combined with self-calibration, meaning that the patient can insert a catheter twice or 3 times a day just to maintain the opening in the urethra once that scar tissue is adequately stretched out. Okay, so the other treatment option that we mentioned was direct visual urethrotomy, the DVIU. Again, there's a low complication rate. It is an outpatient procedure. It is non-curative. However, there are several patient selection factors that I would consider if the patient wanted to try this procedure. There is a high recurrence rate as well, and sometimes if the stricture is close to the urinary control mechanisms where the muscles are, as I showed you in the pelvic floor, sometimes those can be damaged, and it can lead to incontinence if 1 or 2 of those mechanisms of urinary control are damaged. So there is a risk of urinary incontinence with this procedure if it's next to the muscles. And then there's open surgical repair, which is a urethroplasty. This is the gold standard treatment option. There's good long-term success rates, but it does involve a lot of planning and preparation for the surgery. And as I said, if you do a stage repair, it could take from anywhere from a 12-month to 18-month process. And it is a specialized surgery, meaning that you do need to have a reconstructive specialist perform the surgery for your best outcomes. And then the last thing was the other alternative I mentioned was the perineal urethrostomy, which is if you want to avoid a long reconstructive process, healing process, it could, and you can select this option. There is a lifestyle change in the sense that if this is performed, the gentleman would have to sit down and urinate. But it can be temporary, and it's not for men that have inability to control their urine if they leak or if they cannot expel the urine. Okay, those are the other considerations I would think about. So in this study, I just wanted to explain what is currently being done in the United States. And this study was a recent study performed by a group up in Seattle. They looked at national claims data for 4 years time period, and they showed that there is a high variation in treatment options for urethral strictures. You can see that with each metropolitan area, there is the darker circles represent areas that do more urethroplasties versus endoscopic treatment. But they found that there's a high variation. As you can see, there's many different shades of blue on this, from white to blue on this map here. And they also found that there is even though urethroplasties have a good known success rate and is the gold standard treatment, there is a lot of bias still for endoscopic treatment for male urethral stricture disease. So when I see a patient with urethral strictures, usually in the clinic, I like to talk to them about, what are the treatment considerations, get to know the patient as well. I like to know what their age is, what causes, or what they thought was a cause of urethral stricture, also history of any previous treatments, if they've had previous dilations or DVIUs, and also any other concerning medical conditions such as diabetes and smoking, because this can affect or repair going forward after the repair is done. And also in terms of evaluating the stricture, it's important to know how many strictures there are, if there is a stricture in the urethra, how many strictures there are, also the location of the strictures. As I mentioned, it makes a difference how you approach the repair depending on where the stricture is. And also the length of the stricture, and that's also very important in terms of, are you able to reconnect the two ends? Do you need something, an extra piece of tissue, such as a graft from the inside lining of mouth to help with repairing that stricture? And also the degree of stricture, which would let you know how closed is that stricture. Is there any urine able to pass at all? And also it's important to know what the patient's expectations are and how involved they want to be in this process. So in summary, patient selection is imperative. Urethral strictures should properly be evaluated by a reconstructive specialist to avoid any unnecessary repeated procedures. Dilation and urethrotomy are temporizing solutions with high recurrence rate. And urethroplasty, or the open surgical repair, is the only sustainable procedure associated with greater than 75 or 80% of durable cure rate for all stricture processes. Okay, and that's including those that have been operated on. All right, thank you very much. Please ask questions on Twitter using hashtag UCLAMDChat. Thank you. First question is, are men more susceptible to urethral strictures as they age? Studies have shown that there are more strictures in men that are older, but however, it could be, sometimes these processes are so insidious that sometimes men don't know about these conditions until they realize that they're having difficulty urinating or they get evaluated from a urologist. Sometimes, patients will come in with difficulty voiding, and that's when they start to check their prostate out, and then on further evaluation, they find that they have a urethral stricture. So studies are showing that, yes, urethral strictures are associated with men with a higher age group. But there are also a population of young men from either trauma or from playing soccer or riding bikes that can also have stricture as well. But it is associated with a higher age. Second question. What are some preventive measures an athlete may take? For example, a football player or a fighter. Well, I would avoid trauma to the area if that's possible. I know there's cups and things that you can wear, but typically it's not, unless it's like a straddle injury, like a one-time major trauma to the perineum where the pubic bone lands and the urethra is crushed between two hard surfaces. But if you, even with I have a patient that was playing soccer and he was repeatedly kicked in the perineum, and he's has stricture disease, but this wasn't diagnosed until later. But so if you can avoid any kind of trauma to the area, that would be great. I think wearing any kind of support or any kind of cup down there can be helpful to avoid trauma to the stricture to the penis itself. What other complications will happen if I don't get treatment? Well, generally, the complications I measured with infections and functional voiding, ultimately with renal failure or big infectious process, is the two main general complications. Otherwise, it is initially a quality of life kind of a problem issue, but then as it progresses and you don't get treated, the other sequelae is that when you have acute renal failure, that can lead on to other things such as retaining fluid in your body and having to go on dialysis and things of that sort. But luckily, most men come in sooner rather than later and have it evaluated. I don't typically or usually see men with coming in with requiring dialysis or renal failure from stricture disease, although it can happen. If my doctor suspects urethral stricture, how will I be diagnosed? So the best thing is to be referred to a urologist who can evaluate the urethra and also your urinary flow, and that would be the best way. And then, this way we can, as a urologist, we can look into your urinary channel, and we can also have you void and see what things look like, and then we can also perform the studies that I mentioned there to help evaluate for any stricture disease. And then from then on, it's good to see a reconstructive specialist to discuss treatment options in terms of how to repair or fix the strictures. Okay, thank you very much.